I'm Tal Munir. I'm a hematology consultant, and I've taken over the CI role from Professor Peter Hillman for FLAIR and static, and it's my absolute pleasure to be here to be talking about the two important UK studies that we have been able to present, and I'm very grateful for all the patients and UK participants who have participated in these important studies. With me today, I've got two of my very close colleagues who basically work with me on the trials, both FLAIR and static. So it's my absolute pleasure to have Professor Adrian Bloor, who's a consultant hematologist at University of Manchester, and Dr. David Alsop, who's a senior lecturer in hematology at Hull and East Yorkshire Hospitals. So they make a part of our clinical team in the trial management group, and always give me very good insights how we should be running the trial. We've also got Lilia Dooley, who's the patient representative on FLAIR and static trial management group. And Lilia's comments always are the most important ones for us, because the patient perspective is very important. So we will have the first section on the FLAIR on the trials and progress in CLL therapy, which Professor Adrian Bloor will present. And then for the FLAIR data that Dr. Alsop will present, we have got quite a number of publications which are coming out of FLAIR studies. It would be important that David will able to explain that to us. And then Lilia will give her perspective on the FLAIR and static trial management group. And then we'll finish that session off with Q&A and discussion. And then I'll take over on the static, where we are in terms of the recruitment. And then I've got my colleague Rhiannon, who's the senior clinical trial manager at University of Leeds. So she basically helps us to conduct the study. And then Lilia will give us her perspective on how we're doing the trials in that in the management. And then it's over to you, really. You can ask us any questions, and we'll try to answer any of your questions that comes through. But as Hilary already said, that it's important that we take that perspective that we are talking about the trials and not individual cases here. But we would be very happy to answer any questions. Lastly, I would say that CLL is a very heterogeneous disease, so it's a difficult scenario because every CLL patient is unique, in my view. And some patients are on, as we have already seen, are just in that phase, which is called watch and wait or watch and worry. But then there are patients who take a journey of treatment, and it's a long one. But not every CLL patient will need therapy, and it's important to keep that in perspective as well. So I think that's all I have to say, Hilary, and I think I will hand over to you so that you can introduce Professor Adrian Bloor, who's going to take up the trials and progress in CLL therapy.
So thank you very much, Dr. Munir. That's fantastic. And if we could go on to the next slide, please. We've got a magic slide mover on her in the background, you'll gather. And if I can invite Professor Bloor to turn on his video, and then we can hear from you, if that's okay. Thank you very much.
Thank you, Hilary. Thank you, Tal. Thank you very much for the invitation to speak for 5 minutes. Can you hit next slide, Mark? So this is who I am. Thank you to Tal for the introduction. And in terms of this, I'm part of the trial management group for both of the trials. And I've been a haematologist lead for CLL in Manchester for 17 years. Next slide, please. What I'm going to talk about is more about just a couple of minutes of history, really, because it's quite difficult to talk about trials in specific details. For those who are interested in terms of how we've made progress in cancer, this is a really good book. It's a very it's not a technical book. It's not aimed at doctors, but it describes the history of cancer, and I think it makes some sort of important. There's some important things to take away from this in terms of cancer is a relatively new problem, and that biggest cause of death in the 19th century was infection, cancer has become an increasing issue with an aging population. And beyond surgery and radiotherapy, cancer chemotherapy is quite a new thing still. So, and this is a book I'd sort of recommend to anybody to read, but really describes that chemotherapy has only really been around in terms of use since the mid-1950s, and something that we've seen enormous progress in over the last 50 or 60 years. Next slide. One area that I wanted to just highlight here that has really inspired developments of trials and how we try to address treatment has been the explosion of genetic information that we're aware of. So historically, treatment of CLL was with relatively ineffective chemotherapy. And there's really been very much a changed direction of travel. And some of this is because of increased genetic information that we have. So when I did my PhD in the early 2000s, at that point, this was around the time that the Human Genome Project was being in flight. So this was a huge project, 2 groups in the US and the UK. It took 13 years, started in 1990. It cost $2.7 billion and led to the sequencing of 1 human genome. So a genome being all of the genetic material in a cell. So the premise for this for cancer is if you understand the genetics of what's going, what happens in cells, you understand what's going wrong, then hopefully you can then use that to more rationally target therapies. Next slide, please. This then is just a cartoon which shows what we can do now. So remembering in 2000, 13 years, $2.7 billion and 1 genome. If you want to get your genome sequenced now, this is something that can be done. It costs a few £100 and takes about 2 or 3 weeks. And so this is something that has just demonstrated the colossal progress that's been made in understanding human and cancer genetics over the last 20 years. And it's important because one thing that I get asked is, why have I got cancer or why have I got CLL? And it's this recognition that CLL, like all cancers, is a genetic condition, not something we're born with, not something that usually we pass on, but something that has gone wrong genetically in our blood cells that makes them cancer cells. And understanding that should give us insights into what we can target. Next slide. So this is just to illustrate really how it is that by understanding the biology and the genetics of CLL has allowed us to make progress through trials in order to have much more specific treatment. So what this shows is a complicated slide, but the cartoon, it illustrates what's going on in B cells. So CLL cells are abnormal B lymphocytes, types of blood cells. And the way that they work, so this is something that illustrates the fact on the top of the slide, you've got the outside world, which is how the cell interacts with the environment. And then it switches off and on or off a lot of signaling pathways. These are shown by these red, the blobs in the middle, which will activate or deactivate pathways. And at the bottom, the nucleus, the genetic machinery of the cell. And so activation of the outside leads to the cell becoming activated, leads to something happening. Next slide. Have the next slide. So this is just to highlight, this is the B cell receptor. So the B cell receptor is present on both normal lymphocytes and also on CLL cells, and it's how the cell talks to the environment. And the important thing here is that if you switch off the B cell receptor signaling, the cell dies. And so it could be a potentially very powerful tool to treat CLL by targeting the B cell receptor. And one of the ways that you can do that, if we have the next slide, is by inhibiting molecules that are downstream of it. So the idea being is that you've got something that activates the B cell receptor and it switches on a cascade of proteins downstream of it, which make the cell divide. And some of the more important ones here, just illustrated, PI3 kinase and BTK. Important from the perspective of these are the targets for some of the drugs that we've been using in the clinic in the last 20 years. PI3 kinase inhibited by idelalisib, a drug that we don't use so much of now, BTK inhibited by ibrutinib, acalabrutinib, and zanubrutinib. So this has been a really good example of how it is. You understand the biology of the disease, you understand the genetics, and that then leads to rational therapies and designing targets. Next slide. And so using this information has led to this explosion of new treatments for CLL, which has been fueled by trials. So historically on this, on the left-hand side, state of the art of 1950 steroids and chlorambucil, which stayed the state of the art for the next 40 years. Trials tended to come along one at a time in the 90s and the early 2000s. Fludarabine became FC, FC became FCR. But then with this new genetic information, with the advent of newer therapies, an explosion of new treatments driven by clinical trials in the 2010s, leading to the licensing of ibrutinib in 2014. And where we sit now has just been where we are in this great position that we've got a great understanding of how CLL develops and new things that we can do to try and target, which we're going to be the subject of trials going forward. Next slide. So has this made things better? Well, I think the answer is yes. And why do we do trials and why do we make improvements? Because it leads to improved outcomes. So these are data from the US SEER database. This is just collecting data about survival. And what it shows is 10-year relative survival compared to age-matched controls. It's not perfect. If you go back to the 1980s, on average, CLL patients live for about half the time of age-matched peers. And that's improved by 50% if you jump forward by 20 years. So I think that it's something, there's a lot of reasons for them, but one of the reasons for it has been understanding the biology of the disease, designing new treatments, utilizing new therapies. And a lot of this is driven by trials. It also illustrates we've still got a way to go. We want to get this to the fact of, can you cure CLL? At the moment, no, but that's going to be the ambition in years going forward. And that's really the foundation, the question as to what we're doing with CLL trials in the next 20 years, and hopefully we'll continue to sustain the progress that we've made over the last couple of decades. Next slide. So that's where I'll close, and that's really an introduction to trials. I would say to you that despite what's presented as being this marvelous progress, it can sometimes feel like you're trying to push boulders uphill in terms of doing it. There's a lot of bureaucracy around trials, but we really like to acknowledge the enormous amount of work that's been done by my colleagues, Tal, the rest of the team, in terms of getting things off the ground and continuing to move things forward, sometimes in the face of what can seem like fairly unassailable obstacles. Thanks.
Thank you so much, Adrian. That's fantastic. I've always been told when you look at boulders going uphill that the trick is to get the right size of wedge to secure progress. So I think it's a question of, I think we're getting there with the wedge size. So I'm really pleased now to be able to introduce Dr. David Alsop, who's going to talk to us about an update, actually results from the FLAIR clinical trial. So over to you, David.
Thank you very much, Hilary, and thank you for inviting me to speak. So I'm David Alsop. I'm a senior lecturer in haematology in the Hull York Medical School, and I'm also a haematology consultant in the Hull hospitals. The next slide, please. So I'm here to talk about the FLAIR clinical trial. And FLAIR is a name derived from the full title, which is Frontline Therapy in CLL, Assessment of Ibrutinib-Containing Regimens. So FLAIR is a much catchier and tighter title, so we go with that. Next slide, please. So FLAIR is a clinical trial that was tried to help us understand what the best treatment is for persons with chronic lymphocytic leukemia who need therapy but have never had previous treatment. So as I'm sure lots of people on this call are aware, some people with CLL are diagnosed incidentally and the disease sits there and never really changes. Other people, though, have disease that makes them feel unwell, so it can cause them to have low energy, maybe lose weight, have swollen glands in the neck or under the arms that can be uncomfortable. Or some people have disease that, whilst not causing any symptoms, we can tell from the blood test that it's moving forward fairly quickly and at some point will cause problems and need therapy. So FLAIR was trying to work out what really is the best treatment for these people. And at the time that Professor Hillman designed the trial with our colleagues in Leeds, the gold standard therapy was a chemotherapy regimen that we shortened to FCR. And FCR stands for fludarabine, cyclophosphamide, and rituximab. And this had been shown in previous studies to be the best therapy. The trial started in 2014 and closed recruitment last year. And for about 1,400 people with CLL in the UK took part from about 100 different sites. And I'd like to thank every single person and every single person with CLL that agreed to be treated in this trial, as every single person has contributed to advancing the knowledge about CLL and helping improve the care for people in the future. And it was also conducted at 100 hospitals around the country. And again, I'd like to thank all my colleagues around the country who've took part in this trial. And as I said, the trial was aimed to try and work out what the best treatment is. The study, as I'll come to in a second, allocated people to different treatments and also used very sensitive laboratory tests to assess how well people responded. And these laboratory tests look at something called minimal residual disease. And that's a phrase that just describes the detection of very, very low levels of blood cancer after treatment's been given. And it's been worked out again by my colleagues that work in Leeds that measuring these very low levels of disease can give you useful information about how you give treatments. Within the study, people who took part were asked regularly how they felt, as the most important aspect of giving treatment is to make people feel better. We're not aiming to make numbers on computers around blood tests look better. We're aiming to make people feel better. And within the study, we also looked at genetic markers that are known to be associated with outcomes in CLL to see if we could identify groups of persons with CLL who would respond better or less well to various therapies. Next slide, please. So this is a very, very sort of rough schema of the trial. So the FLAIR clinical trial has allocated people over the course of its conduct to 3 broad treatment regimens. One regimen is chemotherapy, which is seen here on the left, and that's this regimen of fludarabine, cyclophosphamide, and rituximab. And the fludarabine and cyclophosphamide are chemotherapy tablets that are given for several days, once a month, along with an infusion of a drug called rituximab. And rituximab is something called a monoclonal antibody, and this sticks to the cancer cells and makes them more sensitive to the chemotherapy tablets. And as I said, at the time the trial was designed, this was the gold standard treatment and is a highly effective therapy. And the chemotherapy has been compared to tablets called ibrutinib. And ibrutinib is a tablet that targets a weakness in the cancer cells that Professor Bloor mentioned, this protein called BTK. And ibrutinib switches BTK off, and this tells the cancer cells to go to sleep and ultimately kill themselves. And ibrutinib is given daily, and within the trial, it's given up to a maximum of 6 years. And initially in the trial, the ibrutinib was given in combination with rituximab infusions for 6 months. But after a while, it became clear that the rituximab infusions didn't add a great deal to the ibrutinib, and the trial was changed to just have ibrutinib on its own. And then a few years after the trial started, it became possible to give people a different regimen, which is the tablet ibrutinib and another tablet called venetoclax, which are given together for up to 6 years. Next slide, please. So the first set of data that the team received was to do with a comparison between chemotherapy and ibrutinib with or without rituximab. And the chemotherapy is given for 6 months, and then after 6 months, the leukemia should have responded and everything should have got better. Any swollen lymph glands should have shrunk down, the blood count should look better, and hopefully someone feels better. And this was compared with ibrutinib tablets, which are given every day for 6 years with some infusions. And the trial found that both were very, very effective treatments. So more than 9 out of 10 people who received either chemo or ibrutinib responded to these treatments. And response means that lymph glands got smaller, blood counts got better, and people felt better. And the trial found that on average, if you receive the FCR chemo, on average, the leukemia stays quiet for around 5 years before becoming active again. And signs of the disease becoming active will be, say, maybe the white cells starting to go up or the lymph glands starting to enlarge. And it was found that the ibrutinib tablets kept the CLL quiet for longer than 5 years. And the ibrutinib is so effective that we don't know yet how long the ibrutinib keeps the leukemia quiet for, because there's not been enough people have disease become active on ibrutinib therapy for the trials team, for Rhiannon and her colleagues to work that out. So it seems pretty clear that ibrutinib keeps the leukemia quiet for longer than chemotherapy. And it seemed to work particularly well in people who have CLL characterized by genetic tests that predict a more active disease, predict disease that's more progressive. When we look at this thing, minimal residual disease, paradoxically, the chemo was better at initially eradicating measurable disease. The ibrutinib seems to work in a completely different way. So people on ibrutinib still had detectable CLL, but it was suppressed and effectively put to sleep. Overall, both treatments are very well tolerated. In terms of toxicities and side effects, the chemotherapy causes more infections and low blood counts, whereas the ibrutinib can be associated with more problems related to high blood pressure and heart rhythm abnormalities. The next slide, please. The other component to the trial was that the chemotherapy, the FCR chemotherapy, was laterally compared to ibrutinib tablets, which say given daily for 6 years, and then another tablet called venetoclax was added in after a few months. And venetoclax targets a different weakness in cancer cells. It targets a protein called BCL2, which again it sends messages to the cell to say stay alive. So if you switch BCL2 off, the cells kill themselves. Within the trial, what happens is people who are allocated to ibrutinib and venetoclax, they initially get a few months of the ibrutinib tablets, and then venetoclax is very slowly added in over a period of 5 weeks. Start off with a tiny dose and build it up and build it up. And the reason we do that is the venetoclax is so effective, it's such a good treatment, that if you start the venetoclax straight away at the normal dose, all the cancer cells die straight away, which is great. But when a cancer cell dies, it releases its contents into the blood, and that can clog the kidneys up and cause something called tumor lysis syndrome. So to get around that, we sort of introduced we've gradually increased the dose up until the top dose. And in the trial, there was no significant occurrences of the tumor lysis syndrome. And in people who had ibrutinib venetoclax, they were monitored with sort of examination and blood tests, and also these very sensitive minimal residual disease tests. And in people who responded really well to the ibrutinib venetoclax, and in whom these minimal residual disease tests showed undetectable levels of blood cancer, then the treatment could be stopped after a period of time. So again, within the trial, ibrutinib venetoclax kept the leukemia in remission, kept the leukemia quiet, so for much longer than chemotherapy. And of people who received the ibrutinib venetoclax, more people were alive. So more people were alive on the ibrutinib venetoclax at the end of therapy than the FCR treatment. So this means that ibrutinib venetoclax is associated with what's termed an overall survival advantage. And this is the first time this has been shown in CLL. It's the first time that FCR as a treatment has been beaten in a good way by another therapy. And in people who received the ibrutinib venetoclax, about 3/5 of them were able to stop the therapy because they had a really good response as detected by these sensitive lab tests. Overall, both therapies, chemo and ibrutinib venetoclax, are safe and effective. In terms of side effects, again, there were more heart problems, blood pressure and heart rhythm problems with ibrutinib venetoclax. There's more problems with infections and also cancers other than CLL in people with chemotherapy. The next slide, please. In addition to that, FLAIR, the FLAIR team tried to look at a small subgroup of people with CLL who have disease that is more active than others. And this more active form of the disease can be characterized by a genetic marker that's got various names. We sometimes call it P53 or TP53 or loss of 17p. But in essence, it's an abnormality that makes the leukemia cells much less sensitive to conventional chemotherapy. So within the trial, we tried to look at whether ibrutinib or ibrutinib venetoclax was a better treatment, which was the best treatment for this group. And the trial managed to recruit a lot of these patients, but unfortunately, because of the rarity of the condition and the fact that we're now in the really happy situation of having lots of active treatments, this part of the trial had to be shut early. Next slide, please. So in summary, ibrutinib tablets, with or without rituximab for up to 6 years, is at least as effective as chemo at controlling CLL and keeps the CLL quiet for longer. And ibrutinib and venetoclax, combined with sensitive monitoring tests, is actually better than chemotherapy. Thank you very much.
Thank you so much, David. That's really, really helpful to hear.
Sorry, I went over a bit.
That's all right.
Lovely.
So we've now got Lelia Dooley talking to us. In fact, it's Professor Lelia Dooley because she was a medical professor earlier on in her career. And Lelia has been a patient and public representative on both the FLAIR and the static trials. And any of us involved in the CLL community ought to be immensely grateful, both to all the people that have helped run the trials that we've been hearing from, but also to people that have been involved on the other side, making sure that another part of the same side, making sure that the trials work as best they can for the patients and the public. So Lelia, over to you, if I may.
And I'm going to talk about, just very briefly, about patient and public involvement in the FLAIR trial. Next slide, please. So the first question, what is patient and public involvement? And this is a very simple definition that's widely used, which that patient and public involvement in research means research that's done with and by the public, not to, about, or for them. Next slide, please. But I think sort of today, really, it's a moment in a way to celebrate the success of FLAIR, which really, I think we've had a fantastic demonstration of what good quality clinical trials can do to improve the outcome for people with CLL. And I would just endorse what others have said, which is congratulations to everyone who's been involved in FLAIR, and in particular those who took part and those who are continuing to take part, because although recruitment isn't ongoing any longer, there are still a lot of people who remain within FLAIR, and I know there's a few of you on this webinar. And then just very briefly, a few people have mentioned, my colleagues have mentioned the trial management group, which is responsible for day-to-day running of the trial. So it's important to have a public patient voice within that. And I joined the study in June 2018, so not from the beginning of the trial. And I think one of the key roles for patient and public involvement is to share the results of research studies, particularly clinical trials, within the community. So for us, within the CLL community. And if you're interested, we have plain English summaries of the results that you've just heard from David, of the first two big publications from FLAIR, and there will be lots more, but they're available on the CLL support website. And I think they underline the importance of trials for people who are having their first treatment for CLL. Thank you.
We've had some questions raised in the Q&A area, and I just want to cover those first of all. There's a very general one to begin with before they'd got on to listening to the detail of what you're saying. So there's a question here about, can having CLL for 20 plus years without treatment cause other cancers? Anybody want to comment on that one?
I can take that. The answer is yes, that there is an increased incidence of other cancers in CLL patients. Some of it's to do with reduced immunosuppression, with reduced immunity. So one of the reasons that we get cancers is where your immune system is weakened and therefore is less able to deal with cancer cells as they develop. And so skin cancers, for example, are more common in CLL patients, even if they've not received therapy. The risk goes up with treatment, particularly with chemotherapy, and it's one of the reasons that we're keen to avoid using things like FCR, because if you use conventional chemotherapy, that adds additional cancer risk, but it's there as a baseline. There isn't anything specific that's recommended to do about it beyond normal cancer screening, so bowel screening or cervical and breast screening in women. Making sure, sort of being vigilant. I'd always recommend to my patients not to go over the top, but just to sort of think about it and don't sit on symptoms if you get them. And skin cancer is the particular concern. So they're not melanoma skin cancers. So there's often things that are very treatable, but being careful in the sun, high factor sun cream, not just putting on oil and baking would be good. And then if you get any funny skin lumps, then going to see your GP about it just to get them checked out would be my general advice.
Thank you.
Yeah, I'd agree absolutely with Professor Bloor there. The other thing I'd say is that obviously the usual positive lifestyle messages apply. Try not to smoke, be active, try and maintain a healthy weight if you can, and all those can make a real difference.
Good. And Dr. Alsop, it isn't a question, it's a comment in here that says, thank you, Dr. Alsop, for actually confirming CLL fatigue and underarm discomfort. Far too many times we've spoken to specialists and been told this is not CLL and it doesn't cause fatigue especially. It's the biggest single factor in my partner's journey so far. So any comments you want to make back on that?
So fatigue, which can be disabling, it can certainly be a symptom of CLL. So obviously I can't speak to the specifics of the question, but absolutely, sort of fatigue, low energy, which can be disabling, can be a real issue for some people.
Thank you. We've got another one here about how long do the increased risks of blood pressure and heart problems last after treatment stops? Is it directly related to the treatment? So when tablets stop, the risk goes back to normal?
I think I probably can answer that question. Looking at the data for the BTK inhibitor therapies, some BTK inhibitors have had a higher risk of high blood pressure and rhythm problems. Ibrutinib, actually in FLAIR study, we also looked at this question as well. But all the data suggests that this is a cumulative risk that we need to monitor patients for high blood pressure. And this is one of the things that we learned in the study as well as we went along. And that was very important for us to know that. But when we look at the data of these therapies, when they are given for a short period of time, what appears to be accumulating data now is that the risk does go down as once the patients have come off therapy. But there is always sometimes an inherent higher risk of developing blood pressure. So lifestyle choices and all of those things to reduce the risk of getting this problem is important as well. So I would say certainly there is a factor from the drug itself, but then there is other risks which are associated with high blood pressure as we normally see in our normal daily life.
And this is all part of every person with CLL being unique. It sort of adds to that, doesn't it, in many dimensions. There's another question here about the ramping up of a new drug is done very carefully, but this person was taken off ibrutinib very suddenly after 6 years with dramatic results when their CLL came rushing back. And they're wondering, should the ramping down be done slowly or be overlapped with the next drug if there is one?
So I must say, I looked at that question, and I think I feel for the member who's raised the question. I think the intention on FLAIR study was that patients will have 6 years of ibrutinib-based therapy, and then hopefully they would move on to static study very quickly. And that would have given us an opportunity to see if we were able to stop therapy and restart the same drug again. And that's what I was going to talk about in static. But we knew that the static study took a long time to open, and there were a group of patients who actually have to come off the therapy. And unfortunately, some of the patients' disease control is not as good as another patient. And that's why I always say it's a unique situation. Every CLL patient is unique. So the answer to the question is that taking off the drug very slowly, I don't think that makes a lot of difference. I think it's important that the disease control is very good before we stop therapy. But the good thing is that starting the next line of therapy, most patients are able to respond to that therapy very soon.
And a question here about FCR. So why is FCR looked at as effective as ibrutinib if ibrutinib trial has confirmed people stay in remission for longer? So I think maybe it's a question of confirming.
Will I speak to that, Tom?
Yes.
Yeah, please go ahead.
So the trial was designed more than 10 years ago, so I suspect it was first thought up about 11 or 12 years ago. And at that point, lots of lines of evidence show that FCR was highly effective. However, not without its problems in terms of infection, people feeling quite ill on the treatment, and a small increased risk of other cancers. And then the new treatments like ibrutinib and other ones came along around 10, 12 years ago. And so the trial at that point, it was unknown as to whether ibrutinib would be as good as FCR. I'm inherently a skeptic about everything, so I thought ibrutinib was highly effective treatment, but I thought there's a chance of it being better than FCR was quite small. But as time's gone by, I've happily been proven wrong, and ibrutinib and other tablets are as effective as chemo. And so myself and Dr. Munir and Professor Bloor almost never or never give chemotherapy with FCR now. So we've taken note of the evidence that's come through internationally, and practice has changed, and the practice is unrecognisable now.
I suppose the only other bit to add to that is that FCR can be fantastically effective. We wouldn't necessarily start it today, but we've all got patients who've had FCR more than 10 years ago, some of whom are still in remission. And it's speculative to say that some of them may be cured. I mean, cured was a very difficult thing to bandy around in CLL because it's a very long treatment history. But as you know, David and Tal know, there are a group of patients with FCR who get out to 10, 15 years still in remission and are possibly going to stay there. Of course, we don't know the answer to that because FCR is also still relatively new. The FCR trials were done were only done 10 to 20 years ago. So when we talk about cure, I really want to be seeing 20, 30 and 40 years of follow-up. So it's a watch this space. But I think those people who had FCR 10 years ago, had 6 months of treatment and are still in an MRD negative remission, haven't been badly served by it and could do extraordinarily well going forward. So, I think it's not a bad thing, but not one that we would necessarily start today.
Fascinating how it's changed over the years, isn't it? And amazingly encouraging. I mean, I think that's one of the big points. A final question before we move on to the second part, and there are lots more questions, but we'll have a look at these afterwards and try and get some responses back through our newsletter or through a bulletin to you all. But for those of us on the I+V arm, how long is the disease kept quiet for after treatment on average?
Maybe I can just come on that. So I think the answer to that question is that we are still in the process of getting that data. The initial data is looking at a median of around 4 years at the moment. So we have got a group of patients who've stopped therapy and some patients who are still on therapy. So David quite eloquently talked about how we use this MRD test to design how individual patient will be needing therapy and for how long. This is a unique concept which is being used only in FLAIR study. There has been other trials where this combination is being used in a fixed duration approach, which means everybody gets 15 months of ibrutinib and venetoclax, and then they will stop. Everyone will stop at that point. If we look at the updates for that day, for those trials, it looks like that nearly 6 out of 10 patients are still disease-free at around 5 years. But we feel that if we took an adaptive approach, depending on individual patients' response, that would be better than what we got with fixed duration approach. So it's something we might come back in 3 or 4 years' time to tell you the exact answer for that, but I don't think we have got the answer to that question completely.
Thank you. And just before we leave this session, Lily or Rhiannon, I'm afraid I haven't had a chance to, there aren't any questions I can direct specifically at you, but Lily, I just wondered if you wanted to say anything about the ASH results, the results that were recently reported at ASH, because it sort of follows on from what everybody's saying, and people won't necessarily realise the significance of the findings that we've been talking about on the call.
Well, I think that's ASH is the big American hematology conference, which I think is the sort of global forum. I think there's others, Tal and David and Adrian, might be able to chip in here. But that was, I think there's been a lot of interest, particularly that was the FCR versus ibrutinib and venetoclax comparison. And I think that's generated an enormous amount of interest because although it's still early days and it's good to hear the emphasis on the need for longer term follow-up before we get too excited about results, it does look like the I+P, the ibrutinib and venetoclax combination is better, substantially better than the chemotherapy of FCR. But that's using that targeted strategy. And no, I think a little bit of the elephant in the room at the moment is that I don't think that's currently available on the NHS in the UK to give it in that way. So maybe something to finish it would be to ask our clinical colleagues to sort of give some feel of how this might translate into practice into the UK and how this might be. I mean, years ago when I was needing treatment for my CLL, there were no choices really. There are now a lot of choices, which is really exciting and challenging. I think is really how we discuss these with people with CLL would be really important, but it might be helpful just to finish on what these results mean for us here in the UK and the NHS.
So would one of you like to respond to that?
I can start, and I think maybe Dave and Adrian can comment. I think the initial data has been presented now, and it's out in the publication format. We are looking at ways how we would be able to persuade NHS England to look at this data. And what we want to do is to try to figure out a way by which we can present the data to NHS England to say whether this strategy is appropriate for our patients and whether we can get this approach funded in UK. So that process is going on, as most people know that these things take time because NHS has to look at the cost effectiveness as well. So one of the important piece that we are doing at the moment is looking at, is this strategy cost effective to NHS as well, and that would be a very important um, money talks eventually. And I think it's one of the most important piece that we have to present to NHS England.
Fantastic, thank you.
Just,
So can I ask, oh, sorry, Adrian, do you want to come in there?
I was only going to say, in terms of just managing expectations, I mean, it is a very frustrating process in as much as the current ways that drugs are considered, if they are licensed in the UK, is that the company that makes them has to do the asking. There is no route for that to happen. I mean, so it would be trailblazing to get this done. So it might be the right thing to do, and I think would applaud Tel and colleagues for pulling it off. But it is something that it is challenging and something that clearly we'd be working very hard on. But I don't think, in terms of is it going to change anything immediately, it's likely to take some time, and so it's not going to be something there aren't going to be discussions in the clinic anytime soon about using these data. But the good thing is, of course, is that we do have lots of other treatments available that weren't available before, and so definitely the conversations to be had about the risks and benefits of those with clinicians.
And certainly the treatment landscape is revolutionised compared with a decade ago. So I mean, there's far more choices of ways that people can be treated.
Yeah.
Shall we leave that there then? So
thank you very much. And having a very nice discussion, but I would like to just take you through the static trial, which is the ongoing recruiting trial from the UK group as well. So this is looking at intermittent versus continuous treatment strategies in CLL. Next slide. So I think the emergence of the concept, I think if we can just click again, is looking at the evolutionary dynamics into treatment of this another cancer called prostate cancer. So this concept basically evolves from this data that has already been published and looked at in this cancer called the prostate cancer. If you click again, please. So it's basically looking at if we give treatment continuously, sometimes what we find is that there is resistance which develops to continuous therapy. Please, next click. So this is the cartoon which illustrates this issue. So the purple cells, this is a prostate tumor cell, and the purple cells are the cells which are sensitive to this treatment called the androgen treatment, which is given to prostate cancer patients. And what you find is that there is the purple cells, which are the cells which are sensitive to the androgens, and then the green cells, which are resistant cells. And what they found in this study was that if you continuously give androgen therapy without any break, what you find is you treat all the sensitive cells, but then the resistant cells will actually take over, and over time the resistance will develop. Whereas when they used it in a different approach, where they stopped and started therapy, so down in the bottom part of the cartoon, they had some resistant cells. You have a short period of therapy, you stop treatment at that point, and let the sensitive cells to grow again, and then restart the therapy. And what you find is that at the end of the day, you will still have some resistant cells there, but the therapy will still be effective. And that's the primary concept that we took forward in static study, because we are looking at continuous versus intermittent approach in this cancer as well. Next slide. And the other concept that is coming along is, this is a very complicated figure, but I think Adrian has talked about this protein, the Bruton tyrosine kinase, the BTK protein. And if you just look at the side, really, there is this part of the BTK where actually Bruton binds to. It's called the C481 That's the kind of the place where ibrutinib or the other drugs called acalabrutinib or zanubrutinib will bind to this area. And what we find is that with a long-term therapy, some patients clones CLL cells will start to acquire mutation in that area, and then these drugs start to become ineffective. So that data have also been published now and coming through in from different groups as well. Next slide. And this is some of the data that has been published. It's a big series of about 419 patients. If you keep clicking, if that's okay. And what we find is that the patients who've had no therapy in the past, so these patients have never had been treated for CLL. In those patients, when we looked for these mutations, we found very little mutations, the BTK mutations. That's around looking at around 2.8% of the patients. But when we looked at the patients who've had chemotherapy in the past and then they had other treatments as well, you can see that nearly 1 in 3 patients has acquired that mutation. And those patients had high risk disease, the TP53 deleted disease. If we keep clicking, if that's okay. Oh, it's going back. And there are other mutations that we're finding. So in terms of what this data is telling us, that actually with continuous therapy, we might see this as a problem developing over time, and especially in patients who've had lots of therapies in the past. Next slide. And what we also, this is again a complicated slide, but if you just look at the y-axis of all of these graphs, the numbers tell us how what was the disease at the start of the treatment, so nearly 100% to start with. And then over time, what we find is that the numbers are going down, and we are seeing that the patients are going into remission. And some of the patients will have had very little disease left after they had 6 years of therapy. And I've just shown you the graphs for ibrutinib treated patients. So we know that when patients have had nearly 6 years of treatment, the disease bulk is much lower as compared to when patients have started therapy right at the beginning. Next slide. So that took us to this trial really, and what we wanted to look at, that if our patients who've had nearly 6 years of therapy on FLAIR, or patients who had are not on FLAIR, but they have had treatments in the past, if we give them ibrutinib either as stop and start pattern, or we give them continuous therapy, we might get similar outcomes or even better. So this is the main concept of this trial. We are hoping to recruit 800 patients. Half of the patients will be randomized to receive continuous treatment, which is that they're not going to stop ibrutinib, and the other half of the patients will get intermittent therapy, which I'll try to explain in the next slide or so. But that's the experimental arm of the study. And we want to look at whether the disease control will be the same if we apply this strategy. We also knew from FLAIR study that after 6 years of therapy, some of the patients, and again, I will go back to that not every patient is this CLL patient is the same. Some of the patients will still need to be on ibrutinib for longer, and those patients can go into this clinical need cohort where patients can continue therapy, but this is only applicable to FLAIR trial patients. Next slide. And this is the eligibility. We're looking for 360 patients coming out of FLAIR, and then 440 patients who had ibrutinib for at least 3 years, and they need to have very good lymphocyte count, which means normal lymphocyte count for at least 12 months. That means that their disease is very much under control at that point before they move into this study. They could be MRD positive or negative. Next slide. And the continuous therapy is standard ibrutinib dose or any other BTK inhibitor at licensed dose, and I will talk about it in a moment. And if you click again, the intermittent strategy means that patients need to be in a very good remission, and I'm talking about clinical remission, which means that the lymphocyte count should be less than 5 and there should not be any palpable disease at all, no spleen which is enlarged. And we will monitor the patients, and as soon as we pick up any of these abnormalities, then the patients can restart ibrutinib at that point. Next slide. And this is how it's going to work. So half of the patients will be getting continuous therapy. That's 400 patients, and half of the patients will be in this intermittent treatment schedule where they will have stop and restart therapy, and then we will assess how they will respond to that. And this will allow us to make sure that we treat all the patients appropriately on the trial. So this study is now recruiting as we speak. Next slide. So I think it's fair to say we have encountered a lot of issues, and the late initiation of the trial is important to remember. We hit the trial start date was around the COVID pandemic time, and it delayed the trial tremendously. And that meant that some of the FLAIR patients who were recruited right early on in 2014 had to stop ibrutinib, but we did allow patients to move on to static even if they had stopped therapy for some time. But the other issue we've encountered now is that the ibrutinib use in the relapsed refractory CLL has been reduced substantially because we've got many more options now, and there are new BTK inhibitors with slightly reduced side effect profile. But the good news is we are working on a trial amendment, and we're trying to open this up for other BTK inhibitors as well. And hopefully that we will be able to get more patients onto the study. Next slide. I think the last thing is what Adrian has already alluded to, that the only reason we are here now at the moment is that the trial portfolio in CLL space has been tremendous in the last 10 years or so. Is this trial taking a next step? And I think it's important to say that no other phase 3 trial in the world is looking at this question, whether continuous therapy is needed for all patients. I would argue that actually we might maximize the benefit of BTKI therapy. Most patients will, we need to utilize the best out of this therapy as well. And really the biological question is whether we reduce the risk of development of these mutations without compromising efficacy, and hopefully we can reduce the toxicity as well. And next slide. Yeah, and I think I will at this point hand over to my colleague Rihanna Lemkin, who basically does all the hard work in the conducting the trial. So she hopefully can give you an update on where we stand in terms of recruitments, and I would be happy to answer any questions.
Thank you very much. Hi, everyone. Yeah, my name's Rhiannon, and I work at the clinical trials unit at the University of Leeds. So I'm part of the team who are sort of involved all the way through the course of a trial. So right when we're sort of thinking about what trial we might like to design, getting it set up, getting it running, and then working right the way through to the end of the trial. I'm just going to give a quick update now, just to let you know all of the hospitals that are currently open to static. So if we can go on to the next slide, please. Thank you. Yeah, just a little bit of information first. Just static open to recruitment back in September of 2022, so just a little over a year now. And the first hospital to open was actually the Royal Cornwall Hospital, who opened in October of that year. And since then, we've continued to work with more and more hospitals to open them up to static, and that's something that we'll keep doing for the next few years as well. And we hope that eventually we'll have around 100 hospitals opening to static. And most importantly, we want to make sure that we're working with hospitals across the entire UK so that we can hopefully reach as many people as possible. So a lot of the hospitals that are taking part have also been part of the FLAIR trial, but we also hope that there will be some who haven't been involved in FLAIR that also open to static. Next slide, please. So currently there are 38 hospitals who are open to static and are recruiting patients. And here you can see a list of all of the hospitals that are currently open and where they're based on the map, which hopefully gives a bit of an idea of where the trial can be accessed at the minute, and maybe gives you a bit of an idea of where the closest hospital to you might be. And like we said, we're working hard to try and make sure that we cover as much of the UK as possible. Next slide, please. So we are also working with another 19 hospitals that we hope will open to the trial soon. So listed here are those that we expect might be the next to open. And so each of these hospitals here will kind of open really as and when they're ready and able to do so. And next slide, please. Thank you. If you haven't seen your local hospital here, it might mean that they're opening in the future, but sadly there are some hospitals who won't be able to open to static. If it is the case that you haven't seen your local hospital and you are interested in the trial, then if you speak with your clinical team, then it might be possible for you to join at another hospital nearby. And we will continue to provide updates on the hospitals that are open to static, but if at any point you do want to inquire if or when your hospital is going to be opening, and if not, what the possible alternatives are, then please do speak with your doctor or your research nurse, and they'll be able to help you with that information. Thank you very much.
Lelia, over to you for your role in the static trial.
Thank you, Hilary. So yes, this is just a few very brief comments on patient and public involvement in the static trial. The next slide, please. So just explaining a little bit of how this works. So it's patients or other people with relevant experience contributing to how the research is designed. So what questions it asked, how it's set up, how it's run, how it's conducted, and then how the results are shared and interpreted. Next slide, please. So why is this important? And I mean, I could have spent the whole hour and a half on this topic, but just very briefly, there's been a lot of research into this, and actually it's really clear that involving patients and members of the public improves both the quality of clinical trials and also their relevance. So how do we do this with PPI? I think it's really important that it helps ensure the research questions are relevant to patients, and I think static is a really good example of that. It isn't the sexy new drug within CLL, but it's having shown that ibrutinib works, and the same principles apply to other interventions and treatments as well. It's how do we best use that resource? And as somebody with CLL, as soon as I heard about the concept of the static study, I thought it was really important from the patient perspective to understand what's the best way to manage this. Do we need to take it continuously, or if you pause your treatment for a while, do you keep it in your back pocket when you might need it later? Will it then still work? And then also it ensures that the studies are designed in ways that are more acceptable perhaps to those taking part. So if you have the condition that's being looked at, you can contribute an enormous amount to making sure that the study actually works for those people who join it. And also that help ensure that the information that those people are given, so the participant information that people are given to read before they make their decision whether to go into a study, is understandable and also relevant to them. And also, if all of that happens, then people who take part in the trials are likely to have a better experience. And particularly for a condition like CLL, where we want to know the results in maybe not just in 4 or 5 years, but maybe in 10 years, 20 years, as has been discussed today. And if you've had a better experience as somebody taking part in the trial, you're more likely to want to complete the study and be willing to complete the study. And then, hugely important, you then hopefully also get better communication of the results to those who took part in the study, because it's really important if you take part in research that you hear the results, and also to the wider CLL community. Next slide, please. So just very briefly, there has been patient and public involvement in static since the very beginning. Both Hilary and myself sit on the trial management group. And just to explain, this is responsible for the day-to-day running of the study. So it brings together all the different people who are contributing. It meets every 6 weeks, currently online. And then we have a separate subgroup of that, which of the people interested in relevant to patient and public involvement, which meets sort of roughly every second meeting, so every 3 months. And currently what we're aiming to do is develop a website for people taking part in the trial. The trial is planned to continue for 9 years, so sustaining patient and public engagement and involvement over that period of time is clearly a challenge. And if anyone listening to the webinar would be potentially interested, then do email us at CLL Support and we'd be happy to have a conversation with you. Thank you.
And that's really around taking part in the helping support the trial team, isn't it, rather than taking part in the trial itself that you were talking about there?
Yes, that should have been, yes, I'm sorry if I wasn't, apologies if that wasn't clear.
We were just going to get 200 emails tomorrow about can they join
Yeah.
static.
Contact your hospital to take part, or Rhiannon, but if you'd like to be a patient and public involvement representative is what I was saying, yeah.
I must say, I mean, I sort of following on from what Lily was saying, so I sit on the trial management group, and CLL Support find the whole idea of supporting clinical trials really, really important. We've just set up our own internal little group to try and work out how we can do it even more effectively going forward. And in the same way that the treatment of CLL has been revolutionized over the past 10 or 15 years, the involvement of patients and public in trial design has also been revolutionized. And I was in Leeds last week for an event that they put on every year or 15 months or so of people involved in PPI. And it's just so obvious that the Leeds Hospital Group is so committed to making sure that the patients and the public views are taken into account in every stage of the trial design and development and so on. So I came away, and even though it was pouring with rain as I drove 140 miles down the M1, I came away hugely encouraged by the whole day. What I'd like to do now is just come back to some questions that we've got. So if anybody wants to put more questions in the Q&A about this particular trial, then please do. Somebody in the box has described it as start, stop and restart therapy. Is that another way of describing it?
Yeah, I think that was a very good way, maybe. Yeah, I think that's a very good way of describing the trial, the experimental arm of the trial. There is, just to be clear, there is a randomization, which is basically the computer decides which arm of the study people will go into, but half of the patients will be randomized to the continuous arm, and the other half would be, stop, restart strategy.
Good. And will there be any way of comparing those who go on to static with those who don't? So presumably this is people from the FLAIR trial, or it could be.
So the comparison basically would be between the two strategies. And what we are looking at is both frontline patients coming from FLAIR and then patients who are on NHS-funded treatment in the relapsed refractory space. I think both will be compared, but at the same time, we will have data for individual groups as well.
Mm-hmm. Good. And somebody going back slightly to the previous discussion was wanting to know how obinutuzumab infusion with venetoclax tablets compares to the treatments in these two trials. Presumably they're the ones that you were talking about, Dr. Alsop.
Yeah, so venetoclax combined with obinutuzumab is a highly effective treatment. the difference between venetoclax and obinutuzumab and ibrutinib and venetoclax is the obinutuzumab is an infusion, a bit like rituximab, that's given regularly for the first 6 months or so. And that means that you have to actually attend a unit or a clinic and have the infusion. But it's given for a finite period of time, and the majority of people respond very well to it. So it's a slightly open question. So it's being looked at, I think, by some of the European hematology doctors as to how venetoclax obinutuzumab compares to other tablet combinations. But it's the current evidence to date suggests it's a highly effective therapy, and any differences will be probably marginal certainly compared to historic treatments.
Thank you. And I've got a question here that I think really is for Rhiannon as much as for Dr. Munir. It's about why might a particular hospital not take part in these trials? My hospital does not. I notice there is only one hospital in Scotland taking part.
Yeah, so I think I can answer that. Yeah, unfortunately, not every hospital might be able to. It's normally for a variety of different reasons. We obviously try and do as much as we can to encourage hospitals if they can to open, but normally it's down to their capacity. If they have the right number of patients that they think they might see that would be eligible for the study, if they have the time and the capacity to take on the study as well. And that's why we want to try and make sure that even if we can't get every FLAIR hospital open, we can cover as much of the UK as possible, so that then you could potentially join at another site. And yes, we do have some areas at the minute where we're not covering as much as we would like. So Wales and Scotland are two of those areas where we've got quite a few gaps. And so we are focusing on those areas where we've got a gap to try and open up a hospital there, so that then we can cover as much as possible.
Good. And we've got a question here about eligibility, and I think we perhaps could do with saying something about the fact there are a whole range of possible clinical trials people can take part in, but the criteria for taking part in FLAIR, which is now closed anyhow, but in static, are very specific, aren't they? So it's not just for anybody on watch and wait, it's for particular people. So would you like to say a bit more about that? I don't know. And Professor Bloor, if you want to.
Yes, I'll just type in and answer that question. I mean, so the criteria for going into a trial are the same as for anybody who wasn't in a trial. So we try and apply them. So, and there's three broad groups of criteria where it's considered: lymphocyte count going up rapidly, so doubling in less than 6 months, anemia or low platelet count, significant lymph gland enlargement, or lots of disease-related symptoms. Now, the difference between trials and non-trials is that for somebody outside a trial, there's more leeway to be able to say, well, we think you need to have treatment, and then you can just, you make a decision, think about the risks and benefits and get on with it. Being in a trial, there's usually then about 30 other things that you need to satisfy that will be related to other medical conditions or kidney function, liver function. So there's a variety of other things, and there's no real flexibility in trials. So you can say no to a trial, but a trial can say no to you, and you have to satisfy all of these things. It's nuanced. I would say broadly it's the same, but it's just a conversation you really need to have with your own treating medical team to be able to look at, do you need to have treatment? And then also what options are available to you. And it can feel sometimes like the trials are trying to find barriers to recruitment, but it's not. It's just to make sure that ideally everybody in the trial is comparable, and also to ensure that there are no safety concerns, because sometimes the trial medication wouldn't be right for an individual based on the medical history.
We've got a question here about how long until we get an idea if intermittent treatment works better. Interested to know, as someone on BTK currently for just over a year. So here you are. This is your $64,000 question.
I think we won't be getting any results relatively soon at all. I think we're just in process of recruiting into the study. So I think we're trying to open the study for people outside FLAIR as well, but those other things, that is work in progress. So if there is any updates, then we would be very happy to come back and talk about that. I I think the results, as Valeria alluded to, that this is a trial spanning over 9 years. So we're playing the long game here. And I think it's probably right to say that it will take some time before we get results out of this study.
Before you retire, though, Tal, hopefully.
I'm hoping so.
So we're just about to share the 2-yearly survey that we do at CLL Support, and we're actually asking some questions about people and their relationship with their medication. And we've got a question here that says, I wanted to reduce my ibrutinib from 3 tablets to 2, as I've had difficulty thinking on 3, but was told I couldn't, I didn't meet the criteria. So what does the team think about this?
So in terms of, as a general principle, we do sometimes reduce the dose of ibrutinib if people are having side effects. There isn't a lot of evidence to show that a lower dose is less effective. And I've certainly got plenty of people who, for one reason or another, are on a lower dose of ibrutinib and seem to get on very well with that. So it is possible to, as a general principle, to dose reduce. Whether that's the right thing to do with that individual circumstance, I'm not sure.
Thank you. And then do we have any information comparing the efficacy of pirtobrutinib and nemtabrutinib? I don't know if it's the efficacy against each other or against...
There are very few head-to-head comparisons generally between BTK inhibitors. So most of the comparisons are sort of implied. So one company will make one drug, and the other company will make another drug, and neither are very keen usually on working together and directly comparing. There's nothing in it for either company commercially. So, but both will be highly effective therapies.
And then does I&V have the same degree of immunosuppression as V&O?
All therapies for CLL are considered immunosuppressive to one degree or another. There may be something about drugs like rituximab and obinutuzumab because of how they work that can cause an increased risk of certain viral infections. But generally, all therapies are considered immunosuppressive, with the effect wearing off a variable period after you stop them. And the CLL itself does strange things to the immune system that can increase the risk of infections.
Right, okay. And then just got 3 more questions here at the end. So first of all, somebody's saying, thanks to everyone involved for a superb webinar. Learning about the results of the FLAIR trial to date has been fabulous. And then somebody's asking, they're on the FLAIR trial, how long is it before enrolling on the static? So can you have a break before you enroll on static, between FLAIR and static or not?
At the moment, that is allowed to have a, if the reason for stopping ibrutinib was that there was 6 years of FLAIR treatment and then static wasn't open, then all of those participants in the FLAIR study are allowed to enroll onto static. As such, we're not now patients who are coming off FLAIR, we want them to hopefully enroll directly onto static study very soon after they finish 6 years of therapy. So only those patients where we were not able to get them onto static study because the static opened in 2022 and some patients were stopped therapy in 2020 on FLAIR.
And any, Delia?
Sorry, is it worth just being really clear there that to go into static, you have to have finished your 6 years in FLAIR, just to be 100% sure that everyone's understood that. It's as you finish FLAIR that you will then be offered static. You can't come out of FLAIR after 3 years or 4 years. Yeah.
Or had a minimum of 3 years on ibrutinib.
Yes, because the
trial. I'll just like to thank you guys and for the CLL support group to invite us to this platform, and to me it was a very lovely engagement, and thanks for inviting us and sharing the platform with us.
So thank you all very much indeed. And with that, I think we can end the webinar and wish you all a safe rest of the day.